40% of patients with cardiac complications are diagnosed with depression. That's almost half of all patients. With this in mind, it's been suggested that there exists a direct relationship of psychological disorders with the heart. My name is Risha Khosla, and my colleagues
Om Mistry
and Noel Lanton
have taken the time to understand the impact of neurological disorders on the heart. Historically, there existed two different interpretations of depression, one being Emil Kraepelin's view of depression as a disease, and Sigmund Freud's view of depression as a result of internalized grief and anger. As of today, depression is classified in a categorical manner instead. It's separated into distinct groups of endogenous and reactive subtypes, which means it's either caused by biological or genetic factors or by a traumatic event. In order to diagnose depression, 5 of the 9 symptoms from the DSM-IV-1 and ICD-10 codes must be present continuously for a minimum of 2 weeks, and the course of depression can last for more than 6 months. Now, before delving into how depression affects the heart, it's important to understand the impact of natriuretic peptides, which play a crucial role. It's important to understand the impact of natriuretic peptides, which play a crucial role in maintaining cardiovascular homeostasis. Individuals with depression exhibit lower levels of atrial natriuretic peptides, which is a hormone that lowers blood volume and relaxes the blood vessel. And because there's a lower level of this hormone, that means that the patient will have hypertension or high blood pressure. Depression also impacts brain natriuretic peptides, which causes the vessels to expand, and the higher the BNP, the more severe the heart failure. C-type natriuretic peptides can lead to mental and emotional changes in heart failure as well. The autonomic system plays a key role in physiological processes as well, such as heart rate, blood pressure, respiration, and digestion. And depression can really influence an individual's ability to control these functions. Depression also creates an influx of catecholamines, which are basically chemicals that send signals to other cells, and this can lead to blood clots because whenever there's damage to the vascular wall, the catecholamines signal platelets to cluster and form a plug. If you have depression, you have high levels of cortisol, which is a stress hormone, and this causes the blood vessels to tighten, and that leads the heart to pump blood faster and stronger. And this could lead to a variety of symptoms, such as rapid heartbeat, high blood pressure, and fast blood clotting. Now I'll pass it on to Om, who will talk about the impact and presence of neurological disorders on the heart.
Thank you, Risha. Depression is present in about 1 in 5 heart failure patients, with about 48% of these individuals being severely depressed. Aspects like your gender, age, ethnicity, social, and financial background all play a big role in escalating the effects of psychosocial disorders on your cardiac health. Psychosocial disorders are also one of the leading causes for non-compliance in patients, especially with cardiovascular patients, with 31 to 58% of cardiovascular patients being non-compliant to medication. It leads to 20 to 64% of these patients being re-hospitalized with a heart failure within 30 days at an enormous cost to the health system. Psychiatric illnesses cost the United States $300 billion annually. Now, talking about your gender. The prevalence of depression in women with heart failure is higher than for men, with women being 32.7% depressed and men being 26.1% depressed. Age is also one of the factors to be considered here. 50% of mental health illnesses are established by the age of 14 and 75% are established by the age of 24. 10% of young adults and children aged 5 to 16 years old have a clinically diagnosable mental health problem. Yet, 70% of these individuals do not get proper help at the proper time. Studies have detailed racial ethnic difference in the diagnosis of mental health problem. While some studies shows that non-Hispanic Black and Hispanic patients have the lowest rate of depression, there are clinical studies that are done that shows us that non-Hispanic Black and Hispanic patients are the lowest among the people who use mental health services. That is only 4.9% of them, as compared to the non-Hispanic white counterpart, which uses 17 to 19% of mental health services. Not just your age, gender, and ethnicity, but your social and financial background also impact your mental health. According to National Institute of Healthcare Management, the prevalence of any mental illnesses has increased by 24% in 2018 as compared to only 8% in 2008. This is an alarming trend, given that mental illnesses leads to adverse health outcomes like heart disease and eventually leads to increased mortality. Now, Noel will talk about the roles of screening, their pros and their cons.
Thank you, Om. Screening is an important part of detecting mental health disorders. The most common forms of screening are the Patient Health Questionnaire, or PHQ-9, and PHQ-2. The one that's most favorable is the PHQ-9 because its accuracy rate ranges from 91 to 94%, whereas the PHQ-2's accuracy ranges from 78 to 92%. Both screens have been enacted since 2001 and are still viable methods for detecting mental health disorders today. Screening is beneficial because at the very least it gives physicians an idea of who is at a higher risk for depression. It is a fact that doctors are 3 times more likely to detect symptoms of mental illnesses after reviewing results from screens. In fact, the U.S. Preventive Services Task Force recommends individuals aged 12 and up to have routine screening. This is because 10 to 12% of young students think of committing suicide every day, while primary physicians tend to miss 30 to 50% of depressed patients and fail to diagnose mental health disorders. On top of that, 1 of 3 students score severely depressed on their screens, meaning they score anywhere between 20 and 27 points, with 27 being the highest number of points one can earn. On the other hand, the PHQ-9 does contain some flaws that contribute to noncompliance and dishonesty when completing the form. The goal of the PHQ-9 is to evaluate the emotional, psychological, and social developments of each individual. We feel it's difficult to do so when the questions are not rephrased for different age groups, especially adolescents who have the highest depression rate at 36%. We also think it's important to note the directness of each question. For example, asking a patient if they ever feel down, depressed, or hopeless, as well as asking if they feel they'd be better off dead, are questions that are just way too direct and way too intense, especially for our younger audience. Like I said, this increases dishonesty and therefore increases the risk of having a misdiagnosis. And finally, the third flaw that we want to point out is the results of the screens are released directly to the patient. This increases self-diagnosing depressive disorders, which affects 5.6% of teens. It also increases the use of serotonin inhibitors, such as Prozac and other antidepressants, which can increase the risk of suicide. Since teens don't know the best plan of action after getting results from the screen, they resort to drug use, when in reality, drug treatments only benefit 1 in 5 adolescent patients, meaning those other 4 could be treated some other way. To address these flaws, we have come up with our own solution, which Om will talk about next.
Thank you, Noel. In order to mitigate the flaws of PHQ-9 questionnaire, we have come up with an age-based self-checkup questionnaire that is constructed to evaluate the social, psychological, and emotional well-being of the patient. We carried out a pilot test at SCAR for the population of age 14 to 20 years old. As you can see here, 57.1% of the population was non-symptomatic, 26.2% were mildly symptomatic, and 16.7% were moderately. As you can see here, 57.1% were non-symptomatic, 26.2% were mildly symptomatic, and 16.7% were moderately symptomatic. We expected 50% of the population to be mild or moderately symptomatic. We conducted this pilot test with small SCARF population, and the results are within reasons with such small population size. This gives us confidence to test it out locally and branch out furthermore. Now, Risha will talk about our plans for the future.
We have spoken to school psychiatrists and district superintendents to compare our questionnaire with the PHQ-9 test. We plan on distributing our questionnaire with the PHQ-9 test for better accuracy, but also we hope that it'll be a supplement to catch that 30 to 50% of patients that go undiagnosed. Moving forward, we plan on passing out pamphlets to frequently visited places such as retail stores, pharmacies, and schools. And because social media is a major source of communication for teens and adults these days, we created an Instagram page to further our message. So join us on our journey to mitigate the impact of neurological disorders on the heart, but more importantly, to mind your heart.